have this, you'll be a good physician. Is not a technician. You have to be a physician which is close to the patient, with which who um collects properly data, knows what have to know, and have good clinical judgment. You see here, it's a statement for Royal College of Physicians from United Kingdom. Medical profession is a vocation in which a doctor's clinical skills and judgment are put in the service of protecting and restoring human well-being. Okay, it's a very nice thing. I put it here. What's happened in the modern medicine? Usually, in the past, it was much more important, this clinical judgment, because the physician didn't have all the investigation that we have today. But the cost of this extensive investigation methods is that medicine is very technical. I mean, you have to know very well your something very good, your supra specialty. Everything has to be done in a very short period of time because of money, because of other thing, and because I'm a little bit older than you, I remember something at the beginning of my practice, when a patient after myocardial infarction used to stay about 2 weeks for recovering in hospital. Now, a patient with myocardial infarction, if it is not complicated, will be discharged in 2 days at home. Uh, but because all of these investigations are very costly, there is a very much attention which is directed to the cost effectiveness. That means you have to reduce costs. You don't have to spend money without a reason. And there is a trend in the last, let's say, 20, 30 years of evidence-based medicine. That means that most of our gesture, medical clinical gesture, are uh, based on some trials um, or guidelines. Less is randomly uh, made, and there is this pressure of patient complaints. It's less maybe in Romania, and I don't know, maybe in some countries, but in other countries in which actually the cost of medicine is very high, and the wage of wages of doctors are very important. A lot of lawsuits are happened because of malpractice or in presumed malpractice. And for this reason, there is a rule which is very important in those countries, let's say mostly in the United States. First rule is cover your ass. That means you do investigation even in excess if they those investigation will rule out some completely improbably thing, but to be sure that is not that, you do investigation, what to do. And for this reason, the cost of medicine become high and high. What are the drawbacks of modern medicine? Like I told you don't have time for a very thorough clinical examination. Actually, nowadays this is less important, but still is the source of the clinical ideas about patient disease. And because you don't spend so much with time with patient, you you fail sometimes to establish a link, a trust link with the patient. And this is not a good thing, because there is something psychology in human mind that need some advices, and the patient wait this advice from his doctor, and this advice for follow this advice, he has to trust in the doctor. I mean, you can have diplomas on your wall, but still you don't conquer the patient trust only with papers. You have to be your attitude to be, let's say, to inspire this trust of the patient. Okay, and because most of the things are happened in acute problems, everything is centered to the emergency room triage. I mean, like I told you yesterday about chest pain, the patient with chest pain used to come to the emergency room, and the doctor from emergency room has to rule out some severe disease which need immediately admission, because this patient has to be admitted. But if this is not the case, the patient, even with sufferance, will be sent home. You don't have something very bad, but still the patient is very, very sick. But this is emergency room philosophy. And sometimes you have the guidelines. Guidelines are made on the base of the trials and evidences. And sometimes in a specific patient, you have a different opinion than that from the guideline. And you have a problem there. You have to decide. I put it already. Now, the guidelines are the most trusted, let's say, handbook in cardiology, at least. It's not the same in every specialty, but in cardiology, it's very important to have guidelines for almost everything. And these guidelines are not perfect. They are statements. Okay, it's written there. What is the guideline? Statements which are issued by different international medical associations or national medical association with precise recommendation for diagnosis and treatment. And this is an example of a recent guideline in acute coronary syndrome patients without persisting ST elevation. You see there are a lot of doctors which wrote these guidelines, and this is an European Society of Cardiology guideline. This issued this. It's written here, actually. And usually in the guidelines, you have some value of evidences. If you have class 1 is the strongest evidence class, and these let's say recommendation are indicated, you have to do it in this case, because there are trials which show that this is the correct way of doing. For class 2, it's not that clear or firm like class 1. You have divergence of opinion, or you don't have enough weight for the proofs for a specific statement. And there is a class 1 in which the weight is in favor and should be considered, see the statement, and class 2B, it's less clear and may be considered that it's permitted. And class 3 is what the evidence, general agreement, show that is not recommended to do in those specific problems. And these are based usually on evidences, which is level evidence 1 is at least 2 randomized clinical trial in favor of this statement. Level 2, it's a single randomized trial or large non-randomized studies. And level C, it's only a consensus of opinion or small studies, not that clear. Okay, I told you this because some of my colleagues will give you example of the guidelines recommendation, and to know what is this and why we discuss all the time about this, because actually in our activity are very important, but they are not infallible without problems. And you see here how I put the recommendation in a guideline. These recommendation, like aspirin is recommended for all patients, you see here the quantity. We speak about non-ST segment elevation acute coronary syndrome. Here is class 1 that is recommended, and the evidences in favor of this are strong. For other things like this with prasugrel, it's class 2A, or this cangrelor, which is a IV form of P2Y12 inhibitor, is class 2B. And finally, you have two statements which are not, I recommend to don't use this treatment. This treatment was used very much 20 years ago, but now it's not considered that it's good for giving. Okay, good. That's a statement of the guideline. There are a lot of guidelines. Everyone has a lot of this recommendation. And for instance, these guidelines gives this algorithm of treating the patient with some disease. Here is a patient with acute coronary syndrome without ST elevation, or acute coronary syndrome. And you see it's very, very nice because show clinical signs. You show that usually the area of chest pain is is large, and if it's larger, it's most probably to have a coronary heart disease. If it's only small, like a point or a small area here, it's improbably. And you see the ECG. It's a normal ECG. This is ST depression, which is associated with myocardial ischemia, and a severe ST depression, which is very strong evidence. And finally, ST elevation, which is usually a sign, ECG sign of myocardial infarction, acute myocardial infarction. And you have here troponin in blood, but it's at presentation. Sometimes it takes about 2 or 3 hours to rise the level of troponin. If it's too early, you don't have positive troponin, even though the patient can have myocardial infarction. And for this reason, they put it the difference in troponin after 1, 2, or 3 hours comparative with the moment of presence of entrance in the emergency room. And you see some differences. And finally, on base of this, you can rule out myocardial infarction, like in mild cases here, maybe it's a non-cardiac chest pain, or if it's not clear, you observe the patient, maybe the patient has no cardiac problem, or can have unstable angina, or even, you see here, myocardial infarction, so on. Okay, this is in a guidelines to see how nice and how clear it is. Okay, and this is an algorithm for myocardial infarction as well from the guidelines, but I want to tell you something. You see, all the cases, severe cases, high-risk cases, or very high or high-risk cases are immediately admitted and sent to coronary angiography or intensive treatment. But if the patient has only a low risk, the patient is sent to home. Even though the patient suffering and is coming to the emergency room because of sufferance, but the patient is sent to home because doesn't have something that severe, and he is sent to be admitted on elective basis. For this reason, there are some group of patients which are suffering, but without a clear or severe classical disease, which are neglected or less treated intensively and sent it to home. And this is a drawback of the modern medicine. And I don't know if some of you heard about Axel Munthe, which was a Swedish doctor who was a Swedish doctor who lived on Capri Island uh, near Naples, and he used to treat patients, and he stated at the moment that the best patients for him, it was a patient with chronic recurrent problem without severity, which come very nice all the time and is not a risk for dying or something else. But still, these patients are suffering. Okay. All of these guidelines are made after these of trials, big trials. But these trials are not done for every problem in cardiology or in other pathology. And because are very expensive, are funded very mainly by the pharmaceutical companies. If you think of what's happened right now, you recorded probably that these vaccines which are developed by specific private company, not by state, only in Russia probably. And these private company have their own interest in promoting some specific drug that they are manufacturing. And these trials are select the patient and exclude those very sick or very old. And when you practice medicine, you see that you have a lot of patients which are very sick or very old. And because of money, these trials cannot have a very long period of follow-up. Usually it's from few months to few years, but not more than 5 years usually. Sometimes they extend the period of follow-up without the full cover of the, I don't know, protocol, only to see how the patient are after years. And all the time, the guidance and the trials and everything is made by after an idea. This idea usually it's put in practice first in clinical usual practice, and after that, doctors, if the things seems to be to working, is put in a small trial, and on the basis of the results of small trial is designed the protocol for the big trial. This big trial is very expensive. I tell you again, it's very expensive, billions of dollars or euros, and for this reason, it's not easy to have a big trial. First time when these trials were adopted was in America in 1962, because there were problems with the safety of some drugs which were put it in clinic, I mean in practice, after small studies before the clinical practice. And one of most one famous drug which has problem is thalidomide. Thalidomide was a drug, see here, which was developed for insomnia, cough, colds, and headaches in Germany, I think. And toxicity was examined in animal experiments, and the drug was introduced in 1956 like a sedative. But when they start to take this drug, they notice that it's very good for antiemetic for the pregnant women in the first months. And even though it was never tested on